Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me for UGG syndrome. This patient has a single piece acrylic lens in the capsular bag with one haptic in the bag and the other haptic in the sulcus. And it turns out this patient also has transillumination defects in the area of the haptic that's in the sulcus, which again confirms that there's active chafing. So you're going to see how we remove and replace this lens for an LI61AO lens in the sulcus with optic capture. So you can see this is the eye, and as you look more closely, there are transillumination defects right here in the area of the haptic that's in the sulcus. And as you shift towards the posterior capsule, you can see there's a rather large posterior capsule opening, a YAG capsulotomy opening. And then on the left side, you can see that there is a nice and intact rhexis with the haptic in the bag, but on this right side, the haptic is not in the bag. And when you look at this patient with gonioscopy at the slit lamp, you can clearly see that the haptic is in the sulcus, and this is the inferior haptic. So I go ahead and make my incisions, my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see that this patient has a rather dirty vitreous as well. As I make my incisions, you can see this vitreous kind of moving around. As I coat the corneal endothelium with the viscoelastic, you can see that the lens jiggles a little bit here. Go ahead and make a 3-0 temporal incision. And this is my prototype Kim capsule dissector. It's mounted with some dispersive viscoelastic. I'm getting underneath the rhexis edge, which I'm able to do rather easily. This patient had surgery about 10 years ago. You can see the transillumination defect I'm trying to show with the cannula right there. Getting under the rhexis edge and pushing viscoelastic to help visco dissect the anterior posterior capsules, and also trying to loosen up that lens. Just going around circumferentially, trying to push viscoelastic and get underneath the capsule as well. It's very important to be gentle. Don't be heavy-handed as you push the viscoelastic, and you're just trying to loosen it up. You can go back again and again and just free up, again, 360 degrees. This is the Lester. I sense that the lens is rather loose, and as I pull on the optic, you can see that the haptic on the left side, which was in the bag, came right out very easily. And this on the right side is the haptic that was in the sulcus. It's obviously not in the bag, so it's going to be rather easy to take out of the sulcus and into the anterior chamber. So I'm just lifting, getting around the haptic, tilting it up, and then popping it into the anterior chamber. And these are the micro scissors and forceps with MST. I don't have any financial interest with them. I'm going to lift the optic up with the teeth closed, grabbing it with the IOL holder, cutting and then re-grabbing as I go. This gives me the best control, cutting this lens in half, making sure I don't cut the capsule and I don't cut the iris. Disengaging the forceps from the lens by pushing it off with the scissors. And then switching to 2 forceps, I have the serrated forceps in the main incision, going after the right hand piece, grabbing the cut edge, and as I do this, the haptic collapses on itself, and I'm shielding the cornea from trauma with the left hand. Grabbing the cut edge on the other side for the left piece, and now I'm going to turn the lens clockwise 180 degrees. Again, grabbing the cut edge, which is the narrowest part, grabbing it, and as I pull it out, the haptic collapses on itself and I shield the cornea with the other forceps. Using a wax cell sponge, I check the main incision, and there is a little bit of vitreous, not a lot, and I go ahead and cut that vitreous. Again, I'm not yanking with the wax cell, but I am having to check it. And there's just a little bit, it's not a lot. And this is a very appropriate technique as long as you're not yanking the wax cell up and off the eye. You're just holding it right there at the incision, and then you can just cut with the scissors. So now this is the Lester. I'm just checking the right side to see if there's good capsule or not. You can see there's very good peripheral capsule on the right and left side. And even though I can't really see the anterior capsule much here, there is some capsule. It might be fused with the posterior capsule on the right side. And this is the AC maintainer. Going to wiggle it into the incision. And then I'm going to do a bimanual anterior limbal vitrectomy. As I do the vitrectomy, you can see, again, a lot of vitreous debris and opacities. I'm using this Bausch & Lomb Stellaris machine. This is my first time using it. I'm having to discuss with the reps the different settings. I believe that the maximum cut rate on this machine is 2500. So I'm switching sides. I asked them to give me maximum cut. Whenever you're doing vitrectomy, you want maximum cut rate. So I'm sweeping the incision. You can see there's vitreous, and then I start eating the vitreous. Again, you want this on the maximum cut rate. So everything looks pretty good. I feel like there is a good capsule support for a sulcus lens. The question is, will I be able to optic capture it? The Rexus is a little bit on the big side, but I think it's reasonable to try, and I do think I can achieve a little bit of a buttonhole technique. And again, I don't have any overlay on this case. I'm using a different fake machine and a different vitrector. So I'm going to push viscoelastic into the sulcus, creating space for the lens implant. And this is the LI61AO lens. This is actually through the smaller cartridge. I actually prefer the larger injector for this type of situation because I don't want that leading haptic to be flailing around. But fortunate for me, the leading haptic goes in nice and planar. And as I deliver the optic, it doesn't change the position of the leading haptic. So my advice is, even though it turned out fine here, always ask for the EZ28, not the EZ24. You want the 28, which is the larger injector and cartridge, so that it'll slide in planar. You want that leading haptic to slide in planar. And I'm using the Lester to dial the trailing haptic into the sulcus as well. So again, nice sulcus position of this three-piece lens. Again, in the United States, the LI61AO lens is the only FDA-approved lens for sulcus placement. So again, I start to do some more limbal vitrectomy, but as I do this, you can see as I pulled out the irrigation cannula, something came with it. And so I'm going to hydrate the left side incision, but the right side incision is a little bit suspect. You can see some fluid coming out of there. But as I check the incision, you can see there's a little bit of vitreous there. So again, I'm not yanking, I'm just keeping it there and just cutting. And you know, when you're doing limbal vitrectomy in this situation, it's really not the best because it just keeps bringing vitreous forward. So I place a 10-0 nylon suture through my main incision. Hydrate my incision and then increase physiologic pressure. And then I'm going to place a trocar. I'm going to do pars plana vitrectomy. It's really the best way, most efficient way, most consistent way to prevent vitreous from coming forward. So I indent the sclera about 3.5 to 4 millimeters posterior to the limbus. I go in tangentially about 3 millimeters away. I stab through the sclera, tunnel through the sclera, and then I dive down perpendicular, remove the blade, and keep the trocar in place. It's okay to have the infusion anterior here, but you want that vitrectomy from posterior. So I start to do the vitrectomy from posterior. By doing it this way, this causes the vitreous to be drawn towards the back, and that's where the vitreous belongs anyway. You won't have any forces that cause the vitreous to come into the anterior chamber, and therefore less likely to have vitreous to the wound at the end of the case, less likely to have vitreous in the anterior chamber at the end of the case, a much more clean approach. And not to mention, you saw that vitreous debris that was there before. Not a bad thing to get all that vitreous debris out. So again, doing vitrectomy from posterior and then anterior, just trying to make sure there's no vitreous that's in the anterior chamber. And so now this is a surgical PI. I had to ask them to adjust the settings to go on low flow and a low cut rate. Point the tip down. Initiate the cutter. There you go. Real quick. And now I have a PI. Pushing some fluid into the eye as I withdraw the cannula. And then I'll hydrate the incisions, take the trocar out, and that will be the end of the case. And so again, this patient had UGG syndrome, transillumination defects along that inferior haptic associated with that same haptic in the ciliary sulcus. This patient had pressure problems in this eye. And one of the signs of UGG is when you have one eye that doesn't have glaucoma and the other eye does, and they're pseudophakic. Normally, glaucoma, although it can be asymmetrical, is typically a bilateral disease. Just primary open-angle glaucoma tends to be a bilateral disease. So when you have unilateral glaucoma, the other eye has zero glaucoma and this other eye has more glaucoma, you just have to ask yourself, and if they're pseudophakic, you have to ask yourself, is there something that caused the glaucoma with the surgery? So I'm trying to achieve the optic capture configuration by pushing the optic down. I know that the haptics are both in the sulcus and they look nice and stable. Never once throughout the case did I feel like the lens was unstable. I did do a vitrectomy from anterior, which again failed to evacuate all the vitreous. So I went ahead and placed a paraplanar trocar, and I have excellent cleanup of the vitreous. Again, the vitreous is in the back. Might as well remove it from the back, not from the front. And so the vitrectomy was done, took the trocar out. You saw the technique of cutting the lens in half and then placing the LI61AO lens in the sulcus. You can see now there's a stable lens in the ciliary sulcus with optic capture. Hopefully this patient's UGG syndrome will be resolved, but only time will tell. So I hope this was helpful to you, and I thank you for your attention.